speaker. Okay, Chief of Pediatric Neurosurgery at MUSC, Dr. Eskandari is pioneering new ways to study the brain through innovative CNS tissue and CSF biobanking. His work turns surgical waste into life-saving research opportunities, and he's generally offering that platform to our community at CTNNB1. So please welcome Dr. Ramin Eskandari.
Well, thanks for coming out after lunch. I get the first talk after lunch, which we agreed is better than the last talk after lunch. So first, I definitely want to thank everybody. I want to thank Emily and Effie and Rachel and everyone who invited me here, especially for the honorary PhD. This is going on my wall in the office. I do not have a PhD, but I will take it. I think this is the universe. You say, you know, will it, and it will happen. But I definitely feel a little bit like a fish out of water here. Imposter syndrome. This is not my typical audience for a surgical talk. But hopefully by the end of this, I will have convinced myself and you that all rare disease talks should become surgical talks. So with that, the only disclosure that I really have that I want to acknowledge is a big debt of gratitude to Anna and the whole Combined Brain team for helping to fund the beginning of this biorepository that I'll describe to you towards the end of the talk. So I had no idea what these letters and number meant until I had my first patient encounter. But what I've found over the last few years, and especially with integrating with a biorepository, is that certain rare diseases, especially genetic mutations, can present in all kinds of ways. And specifically, CTNNB1 has surgical implications that are not quite yet recognized throughout the medical community, but are being recognized and being increased awareness is being brought to them through platforms like yours. So some of the major websites from the foundations are starting to acknowledge something called tethered spinal cord syndrome, which is a rare condition that comes along not just with CTNNB1, but also with many other neurological conditions and other genetic mutations as well. And so having these websites and these foundations start to recognize that surgical diseases do occur within these rare disease platforms, the scientific community, as you guys are part of that, is starting to become aware. So research is being done, but also the medical community on our end is starting to become more aware. And so figuring out better ways of screening patients and starting to refer them to the various surgical subspecialties that need to see them, like us in neurosurgery, but also urology and orthopedics, which comes along with tethered cord syndrome. So what is tethered cord syndrome? Some of you guys might know it. Some of you may have had your family members, your sons and daughters diagnosed with it, and some of you may have even had operations for it. But it can present in all kinds of ways, and the presentation very much is dependent on age and severity. And so when you see something on the back of a child, a young child, especially a newborn child, you start to think of something like an iceberg syndrome, right? Something on the very surface might be hiding something much, much bigger down below. And so early suspicion of this leads to early diagnosis. Early diagnosis leads to better treatment options. The imaging modalities that are usually implicated for diagnosing tethered cord syndrome start with ultrasound. Now, unfortunately, ultrasound is very technical, and it is not the greatest method to see on the inside of bone specifically. So people start to use other imaging modalities, but unfortunately, MRI, which is the best imaging modality, tends to need sedation to be able to get the kids to sit still long enough to get an image. And that's where things like fast spine MRI, which we've helped sort of pioneer, and a few centers around the country are using it now, has become a huge tool to be able to diagnose kids earlier. And this obviates the need for sedation. The fast spine MRI protocols are not only fast to get, but also have motion correction built in. And it's an entire working group of child life and everybody that goes together to get these images. And so when you suspect tethered cord, the kinds of things that you're going to see are skin changes like we saw on the last slide, but also other sorts of changes that have to do with the very bottom of the spinal cord and the nerves that usually come off of the very bottom of the spinal cord. And those are things that are basically from your waist down. So foot deformities, spinal deformities, curvature problems, so progressive scoliosis, clubbing of the feet, and it can be very subtle sometimes, and you wouldn't necessarily think every kid that has a little bit of high arch or inverted toes or anything like that has to have tethered cord, but it's a combination of a bunch of things together. And then as the kids get older and their spinal column is growing, the stretch that happens from the nerves being pulled on too tightly causes sensory and motor changes as they get older. And so during periods of the typical growth spurts in early life are the times when you start to get these symptoms. So sensory changes can be anything from dull pains, achy pains. Usually these pains are different than growing pains. These pains come along with activity versus growing pains, which are usually when the kids first wake up. And no kid, I think I've told a few people this, no kid should ever come up from playing and say, my legs hurt, I don't want to play anymore. That's not okay. No child has ever said that in the history of the world. And so it's never okay that that happens. So you have to investigate that. Motor symptoms can be anything from weakness. It can be difficulty with gait. What I see a lot of is when it's an unknown, it's a child that goes from crawling to walking to crawling, or a child that goes from not crawling to crawling and then not crawling again. So it's getting over a hump of going forward and then suddenly going backwards, and that should be a red flag. Bowel and bladder symptoms are harder because we're dealing with kids that are sometimes before they're even toilet trained, or they have a neurological condition that doesn't even allow them to become toilet trained. So you're kind of working uphill to figure out whether the urological and the bowel symptoms are really associated with tethered cord. But the difference is that tethered cord usually causes retention and not incontinence. And that retention can usually lead to frequent UTIs, and if it's untreated, it goes upward in the pipeline and it causes kidney damage. So these are important reasons why the orthopedic surgeons and the urologists, as well as the neurosurgeons, need to be involved. The typical pattern that we see with tethered cord, and again, this is not everybody is going to be like this, is the very bottom of the spinal cord ends well above the bottom of your butt. It actually ends right around above your hip. And where it ends, from that point on, there's a fibrous tract called the filum terminale, and that's just a little connective tissue band that connects the bottom of your spinal cord down to the bottom of your spinal canal. Usually that's a stretchy connective tissue, normal tissue, that allows for the very quick growth that happens in early childhood. Sometimes that connective tissue band is not normal. Sometimes it's infiltrated with fat, sometimes it's infiltrated with scar tissue. This is all usually congenital. It doesn't grow after birth usually. But that abnormal infiltration is what causes the tethering, and that pull, prevention of the stretch that's normal during growth is what causes the neurological symptoms. So I figured a case presentation might be kind of cool. And so this is a 10-month-old that came to me and happens to be a CTNNB1 patient who was my very first and presented with a sacral dimple. Now, at about 3 to 4 months of age, they received an ultrasound, as typical by pediatricians who see kids with weird butt cracks and sacral dimples and all kinds of things on their lower spine. Now, that ultrasound was normal. Nothing was wrong with it. And normally, if that's the case, you sort of chalk it up to, oh, that's just a little benign dimple, which is very common. However, because of her condition, and because of the high prevalence of spasticity and abnormalities with spine, she was recommended by both her geneticist and her physical therapist to seek another opinion. And the tone changes that happen with this condition are well known. However, she hasn't really gotten too much in the way of ambulation yet. And at 10 months, she can bear weight, but she's sort of scooting around the floor, kind of like army crawling and dragging herself. So she got the recommendation to come see us, and we did get an MRI. And the lumbar spine MRI that we get at our institution is that fast MRI that we talked about. But it also includes a full-length picture, as you can see there on the right side, of the bottom of the brain all the way to the bottom of the pelvis. And this becomes really important because not only can we see abnormalities at the skull base that are associated with tethered cord, but we can also see the bladder, we can see the bowels, we can see all kinds of things, and sometimes we've diagnosed bladder retention on a spine MRI because the bladder looks like a uterus. It's massive. And those are cases where we then immediately refer to urology, not even wait until we get a diagnosis of tethered cord. So in this case, the spine MRI showed a very long segment fibrolipoma, which, I don't know if you can see my cursor, I guess you can't. In the far left, there's a little dot. Right there, that dot is a dot of fat. And as you scroll up and down, what you'll see is that that fat goes all along the entire length of the phylum. So basically, like that picture, the phylum is infiltrated with fat along its entire course. Usually, if there's a little bit of fat, we're not super concerned because the rest of the phylum is potentially normal. However, when there's this much fat, we get a little bit concerned about the potential for tethered cord as the patient grows. So in this case, she saw a pediatric neurosurgeon, me, and we discussed the options. And one of the most important parts of all of this is that you don't jump to doing surgery right away. The goal of surgery is to create some sort of a safety profile. The earlier you do surgery, there are certain positives. The later you do surgery, there are certain positives. And part of those positives is being able to monitor the nerves appropriately. And so the later you do surgery, the better the nerves are monitored. The earlier you do it, the better they heal. So these combination of things ended up bringing us to a surgical decision-making tree, which she ended up getting surgery at 16 months old. She started to have a little bit of clubbing, a little changes in the feet, but surgery went very well. And 6 months later, she was ambulating with assistance and working with our therapist. So that case sort of brings us to what ended up happening afterwards. And so treating individual patients is great. I wouldn't change that for the world. But where does that one patient lead us for advancing rare disease research? And I'll argue that that one patient is the sort of tipping point to us being able to start something very, very unique, which is the first that I know of, and the only one that I know of as of right now, a pediatric neurosurgical biorepository that houses any and all tissue that we go through to do any and all surgery. So this includes basically normal tissue from surgical patients that would have otherwise been discarded, not the patients, the tissue. So in doing surgery, we go through things. We go through tissues, we go through bone, we go through brain, we go through spine, we go through CSF. And in order to do that tethered cord surgery, milliliters of CSF come out, and milliliters of CSF get thrown into the waste. And so now what we're doing is, over a very long period of time and a lot of fighting with our IRB, we had finally gotten approval to be able to do this. And once we got approval for CSF, we then moved forward with brain, with bone, with ligament, with you name it, we kept it. And this is all because of these two amazing people here, who you know. And I'll say that with the last year and a half or so, we've been able to really accumulate a lot of normal tissue. We now have 3 pediatric neurosurgeons that are collecting. This can't be done without a massive help from our biorepository coordinator, Cameron here, who is a total all-star. She comes to the operating room every single day that we have cases. She's there, she collects it, she gets it immediately, goes and processes it. Tissue does not stay unprocessed for more than about 15 minutes. And so most of the tissue is processed within 40 minutes, some of it even before that. And so we started collecting in November of 23. You can see there we're collecting all kinds of different things. We want to roll this out to the other service lines as well. But I figured I'd give you guys a quick update as to what we've collected so far. So we have 66 unique samples of CSF. These are individual unique patient samples, over 1,800 aliquots. Again, these are not all single genetic mutations. These are actually what we consider normal. But some of them do have genetic mutations within the patients. 33 unique samples of non-brain. You can see the list there of the non-brain tissue that we have. Over 300 aliquots of brain tissue, 23 unique patients. And then we've also started doing co-collection of plasma with every single one of these samples. So 30 of these patients also have a combined plasma at the time of surgery. Usually the plasma is taken from a blood draw when they're putting the IV or the A-line in for the surgical operation. So this is all to say that I feel like this is an opportunity where neurosurgeons can actually have an active role in advancing rare disease research, and specifically in neurological diseases where we are in a very privileged position of accessing tissue in a way that no other medical provider can get, and so we need to take advantage of that. You people, rare disease foundations, families, and researchers can influence us. You can let us know that this is important. You can let your community know. You can let your physicians know. And I think the more influence there is from the foundations and the patients that ultimately will hopefully benefit from the therapeutics, the more we will feel the pressure to continue to do this. The CNS biorepository for normal tissue is critical for creating better controls. So a lot of you researchers have to either buy artificial CSF or have to use animal models to do control. We now have opportunities with multiple Ns to have large volume of control tissue and control CSF for you to compare. And I think that gives us more accurate and more safe future therapeutics in CNS disorders. So I know I'm a little over time, so I want to thank you for your attention, and I'd be happy to answer any questions later.
I let you go over a little bit because it's so important, and you're so unique, and I wish you thousands and thousands of competitors to come because we need more.